Room 402 by Jessica Moore, MD. Where are you? Carefully placing my hospital visitor sticker onto my sweater, I wished I was putting on my apron to bake cupcakes with my favorite aunt. You. Instead, I entered another hallway and squinted, adjusting to the harsh fluorescent lighting. A flock of scrubs and white coats sped past me, chattering urgently to one another. The smell of freshly baked chocolate cookies from your kitchen was replaced with wafts of lasagna from the nearby hospital cafeteria and hand sanitizer. An unpleasant combination. Where are you? A nurse smiled as I asked for directions and told me you were in room 402. One of my favorite patients, she exclaimed. I wasn't surprised. Finally, there you were. A pale, shrunken version of yourself swimming in a sea of white hospital sheets. Purple lace shone through the skin of your eyelids. The same hands that overlaid mine Christmas morning as you taught me how to whisk batter were now thin and fragile like tissue paper. Why had you not told me that your cancer was spreading? I pulled an uncomfortable plastic chair to the side of your bed, positioning the periodic table on the hospital floor. Room 402 became the place where I did my college chemistry homework remotely every day. When other family members had to work, I made sure that I was there so you weren't alone. The rhythmic beeping of your heart rate monitor was steady. Clear bags dripped mystery fluids into your veins. In this room, we existed in a multitude of juxtapositions, smells of sterility and staleness, sounds of laughter and weeping, and lines of distress on your brow mingling with moments of peace. As time went on, your physicians visited less often. They stood over us with creased foreheads, frowns, and hands shoved in the pockets of their long white coats. I watched numbers and unrecognizable drug names fly over my head. I didn't try to catch them. When I asked if you would improve, the room fell silent, except for the subtle shifting of the trainees as they anxiously looked over to the attending. It's hard to tell, he exhaled flatly. When your condition rapidly deteriorated, doctors stood by the doorway, an easy escape. They said you didn't have much longer. They did everything they could. They were sorry. They suggested that talking to the hospital chaplain or a grief counselor might help. This conversation felt rehearsed, polished through years of repetition. They all took another step back, half in our room and half out of it, half in our world and half out of it. And just like that, they had moved on to room 403. I placed my hands on your arm. The next morning, you peacefully passed away. Years later, I stepped inside the same hospital, your hospital. I let myself pretend I was coming to see you. It was the first day of my internal medicine rotation. My hospital visitor sticker now replaced with a medical student ID badge. You don't know your niece got into medical school. You'd be proud. Maybe you are proud. The patient assigned to me was Sandra, a 74-year-old who recently received a new diagnosis of pancreatic cancer. She was assigned your room, 402. I now knew how to get there and almost expected to find you. Instead, I met an older woman glancing up from her crossword puzzle books scattered across her hospital bed. I immediately liked Sandra. She was tough and blunt. She reminded me of you when you were healthier. After team rounds, I pulled up a chair in her room. The squeaky plastic one I sat in years ago was now replaced by a sturdier cushioned seat. I looked around and saw Sandra's telemetry monitor reflecting a normal heart rate and blood pressure. Multiple bags of carefully chosen medications dripped into her veins, all documented in my progress note. With you, I knew so little. With Sandra, I knew a little more. Each day, Sandra meticulously picked out a crossword puzzle for me. She'd say, "You aren't allowed to leave until you solve it." As we sat, pencils in hand, she mentioned her family didn't live nearby. They couldn't afford to come and visit. I felt thankful I'd been able to be with you, and that I'm here now with Sandra. Conversation shifted as she made quick-witted jabs at my lackluster puzzle-solving skills. My visits to room 402 became a daily routine. Unfortunately, as the days passed, Sandra became increasingly anxious and easily tired, I visited more often, noticing she had completed all her puzzles. I bought her a travel-themed crossword book to cheer her up. The next day, I found Sandra lying in bed with dark circles under her bloodshot eyes, accompanied by beads of forehead sweat. Looking up at the ceiling, she told me she was tired and nauseous. No puzzles today. I inspected her laboratory results, which pointed to an infection. Elevated white blood cell count, low blood pressure, febrile. Like you, she was getting weaker. Sandra's prognosis was poor, and she needed to be updated. Feeling connected to her, I asked the team if I could be the one to share it. As I remembered receiving your bad news, a pit formed in my stomach. Following my team to room 402 and our flock of scrubs in white coats, I anxiously rehearsed in my head how to tell Sandra she was going to die soon. I reflexively settled into the cushioned chair next to Sandra. The script I had rehearsed, the one taught to me in medical school, left my mind as I took my hands out of my pockets. I placed one on Sandra's cool, frail arm. The rest of the team sat on the windowsill, the end of her bed, and an extra chair. We translated numbers and facts to words we made sure she understood. We answered and asked difficult questions. We shared in her sadness as the news sank in. We sat with her in silence. "How much more time do I have?" Sandra asked, looking at me. It's hard to tell," I exhaled, with a crack in my voice as I stifled back tears. Sandra gave me permission to cry, which we did, together. In that moment, I also cried for you. Looking back, sharing room 402 with you taught me about subtle differences in delivering bad news and how to be fully present in harrowing moments. To avoid reciting numbers and medical vocabulary, and instead to express empathy and share in sadness. To look out for the loved ones of my patients. To be a companion in an empty chair at the bedside. I remember the fear, sadness, and lack of control I felt in room 402 with you. From that experience, I resolved to focus not only what is said, but also on how it is delivered. Although you are no longer in room 402, I know where you reside, within Sandra and every patient who comes thereafter.
Welcome back to JCO's Cancer Stories, The Art of Oncology. This ASCO podcast features intimate narratives and perspectives from authors exploring their experiences in oncology. I'm your host, Mikkael Sekeres. I'm professor of medicine and chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center, University of Miami. What a pleasure it is to have joining us today Dr. Jessica Moore, a resident physician in internal medicine at Boston Medical Center and BU School of Medicine, to discuss her Journal of Clinical Oncology, Art of Oncology article, Room 402. Both Dr. Moore and I have agreed to address each other by first names. Jess, thank you so much for contributing to JCO and for joining us today to discuss your article.
Oh, thank you so much for having me. It's truly an honor. I'm glad to be here.
I promise you the honor is mine. I like to start these podcasts off by asking you to tell us something about yourself. Where are you from, and can you walk us through your career up to this point?
Yeah, I'd be happy to. I actually took a little bit of a non-traditional path into medicine. I went to a small liberal arts college, Wheaton College. I was very much a humanities major. I was a philosophy and psychology major there. And my goal leaving college was to get my PhD in clinical psychology. And that was kind of my trajectory. I didn't have anybody in my family in medicine. So being a doctor was not really on my radar. And I graduated from college and I wanted to do a little bit of research before I applied to grad school. I happened upon a job working with pediatricians who did fellowships in child abuse. So actually, I spent 5 years in that clinic being the research coordinator and putting out publications in regard to child abuse pediatrics, which was a really cool experience. I had no idea how to do research. I learned a lot through that experience, but I think probably the more important piece to that whole job for me was kind of falling in love with medicine and seeing kind of all of the multifaceted ways doctors show up for their patients and all the opportunities and learning that you do within the field of medicine. So I went back to school. I did a post-bac, did all of my pre-med classes, and then got into Brown Medical School, which is where I went. And here I am as a second year internal medicine resident at Boston Medical Center and hopefully a future in hematology and oncology. And that's where I'm at.
That is fantastic. It's interesting. When I was a medical student, I did a rotation on is actually a child abuse rotation that we took at Children's Hospital of Philadelphia, where we spent a lot of time in the emergency room, but we also spent time going down to City Hall in Philadelphia and going to meetings of neighborhood advocates and meeting with politicians and working on getting legislation passed. And I realized from that rotation just how holistically we could view our relationship with our patients and how much those factors played into their health and our perception of their health.
Absolutely. That sounds awesome.
The other thing I have to ask you, since you went to Brown, I was born and bred in Providence, Rhode Island. And of course,
Oh,
I am now completely addicted to the Real Housewives of Rhode Island. Have you checked it out at all?
I haven't, but that is on my list to do. I was, born and raised in Rhode Island myself. So I've heard that it's a good one to watch.
It's like a salve to hear the accents again. So for me, it's rejuvenating.
Yeah, I'll definitely give it a watch.
I wanted to, well, shift gears from the Real Housewives of Rhode Island, which isn't hard to do. Can you talk a little bit about the period of your life when you were spending time with your aunt in her hospital room, in that room 402? Had you decided to go to medical school at that point? What was that time like?
Yeah, that actually was the transitional point of when I decided that I maybe wanted to go to medical school. So I was just out of college. I was working on research at this job I was talking about, and I had decided to start taking some of my pre-med classes. So the story kind of reflects, I think there's a part of it where I talk about balancing doing that work while also kind of being in that room alongside of her. So that was kind of the trajectory of at the point of the very beginning of thinking of going to med school.
And how much time did you wind up spending there?
I would typically go a few times a week. I would kind of camp out and spend most of the day in the room with her for, I would say, like over the course of like 2 to 3 weeks.
It's a lot of time to spend in a hospital room. There aren't a lot of distractions.
No, no, definitely not. It kind of gives you a flavor of what patients and their families go through when they're stuck in these rooms, especially when they're sharing rooms with other patients. There's a lot of commotion going on. There's oftentimes not a lot of windows, a lot of space, and it can be challenging.
What did you talk about with her when you were there? Can you remember?
Unfortunately, she declined quite quickly.
Oh,
And as I alluded to in the story, she was a very stoic woman and she did not really let on to our family how sick she was up until the moment where she was so sick that she was hospitalized. And at that point, she was kind of waxing and waning and, some delirium and some sepsis as well. But, in the moments of clarity, I spent a lot of my childhood with her. So we talked a lot about, she took me to see all of the Harry Potter movies when we would go together. So we talked a little bit about that. She was also, a really avid baker and, taught me some things about baking. So we talked a little bit about that too. Mostly felt like what I served the most for her was, sitting by her side. She could hear my voice talking to my family on the phone, or I would just be aside her holding her hand.
yeah, that notion of presence. We see a lot of essays that are submitted to Art of Oncology that focus on just being present for our patients and for our family members. You can imagine hearing a familiar voice and seeing a familiar person must be incredibly gratifying when they're facing the fear of illness.
Right, exactly.
You write in your essay about her doctors seeing her less often. And I wonder, did you notice that in real time, or was that something you reflected on and recognized in retrospect?
I noticed it in real time. I spent a lot of time in that room. So I think, even before going into medicine, picked up on the patterns of how teams round and how frequently they go in the room. And kind of it was a predictable schedule, and felt like when she was sicker and there was more for them to deliberate and do, they were in the room more in the afternoon, kind of giving us updates. And then I think that there was a shift in the way that the team was thinking about the patient, in the way that oftentimes we as a team, outside of deliberating in front of a family, talks about, okay, I think, we've done everything that we can at this point. And sometimes I think physicians maybe then kind of take a step back and are not in the room quite as much, but that subtle shift in like the way that we're taking care of a patient, I don't think is always communicated with the family. And I think it's something that I noticed before they kind of told me that that was the direction her care was going in.
Hmm. That's incredibly insightful. Do you think that medical teams see patients less frequently when they're dying because there isn't as much of a medical need, or do you think that they're pulling away from someone who's dying? And why is it that we do that? Why do we pull away from someone who's dying?
Another good question. I think one that I think about now a lot in my training, especially on the wards. One, there is the piece of there's not as much medical decision making maybe necessarily needed, but I think perhaps like a larger piece is our comfort around these situations where I think, we're trained to act and do and tell a family what our plan is and the action steps we're taking in order to get somebody feeling better and out of the hospital. And when we reach this point where we're not able to do that, I think it's oftentimes hard to communicate that with families. And, for fear of maybe them feeling like we've given up or we don't quite know the next step. And I think that leads us to maybe spend a little bit less time with families.
It's so interesting, right? Because especially with somebody who has cancer, we're in action mode. There's a problem and we work out a plan to solve it. And it may be a complicated plan, but it's a plan, or it may be a plan that's not going to lead to cure, but it's a plan with some sort of endpoint that we're all focused on. And yet, when someone's dying, I think it almost gives us an opportunity to talk less about the medical and learn more about the person. And that's kind of what people in the room want to do. They want to reflect on this person's life.
Right. And I wonder too if part of it is we want to give space to the family and the people who love and know the patient to be around. But I often think that sometimes coming in as a medical team, families seem to really appreciate that and giving them the opportunity to talk with us about their loved one.
Right. And I've been shooed away also. There's times families don't want us there. They're in a really good place with a family member and we're interrupting and they kind of, they kind of wave us off. We can read those signals too.
Right.
You mentioned that as a medical student, you pulled up a chair to talk with your patient, Sandra, whereas years ago, the doctor stood by the door of your aunt's room. And it was a nice juxtaposition that you had in your essay to kind of contrast those two approaches to someone who was in a palliative mode or entering a palliative mode. What do you think has changed in how we treat people who are in more of a palliative mode in the decade or so that passed between those two episodes?
Hmm. I hope that there's a little bit more of a focus on being just a human in those moments with patients and their families. And there's a lot of spoken things and actions we can do, but I think perhaps what's more important in those moments are the things that are not spoken, where you take the time to be present with the patient and their family. You are at their eye level, you sit with them. I think physical touch, when it's appropriate, can be very therapeutic. I have found in my training that I see more and more doctors doing that with patients and feeling comfortable and empowered to do that and recognizing its importance. And I think there's definitely been an emphasis on in my training where we're taught the importance of doing that.
So you write at the end of your essay that Sandra gave you permission to cry in that moment, right? You just broke some bad news to her and it was an emotional event. How did she do that? How did she give you permission to cry in that moment? And reflecting on what you just said about the changes in how we interact with patients who are at the end of life, do you think showing emotions to patients scares them or helps them when we have a human reaction to their illness?
I don't think I'll ever forget that moment where I had spent a lot of time in that room with this patient, and she and I felt very comfortable with each other. And in a way, I almost felt like she was being protective or looking out for me because she knew that I was taking the news hard and, obviously cared a lot about her. And she was just like, it's okay. It's okay to cry with me. And like I shared in the story, she really didn't have a lot of family. She didn't have a lot of social support. So I think her having like a very human interaction with somebody to kind of share in the sadness with her was what I hope was very meaningful for her and something that I felt. I think that patients do really appreciate that. I think they appreciate that we care and we take to heart a lot of these like really difficult conversations and decisions that we have to make. There was once this movement to be perhaps very like stoic, very robotic, and maybe with the fear of patients and families not thinking we knew what we were doing or not in control of the situation or for whatever reason. But I think now there's this movement where we can like be really connected with a patient and a family. And perhaps that also bridges a connection between us and trust in our medical decision making as well.
And maybe there's not as much of an expectation that we be all knowing, that it's all right for us to say, I can't give you exactly the answer that you're looking for right now, or to say, this is bad news and I've gotten close to you. And so I'm going to have an emotional reaction to it also, just like your friends and family might.
Right. Right.
Was that the first time you gave bad news like that to a patient?
It was. I was, very much a learning medical student on a clinical rotation. I certainly saw it modeled. My medical school had a really great doctoring program where we practiced in simulated situations, delivering bad news, and, had like this whole script. And that's kind of like what I had in mind when I was writing this piece. But I think doing it in real time, I was, nervous, the buildup of it, like I expressed in the piece once I got into the room, just letting that all go and just being a human being and allowing my emotions to be in that space, which I think was appropriate, ended up working out. But yeah, it was my first time. I'll never forget it.
You never do. You never do. When I was a medical student, I was doing my internal medicine's sub-internship, right? So it was this kind of high stakes rotation as a medical student. And I remember the father of one of my undergrad friends was hospitalized to receive an autologous transplant for his lymphoma. And I would visit him every day. I'd go around on my patients, and it was kind of at the end of the day, I'd go and spend some time with him. And I remember from that point on, I always gravitated to that room, no matter which patient was in there, and it had kind of a special place for me. So, at the end of this marvelous essay that you wrote, was it Sandra, or do you think it was the room that drew you in?
I think it was probably initially the room. I very much had this, ingrained path of where I would go, where I'd go to get food after spending a long day with my aunt. And I kind of just followed that path again and the room itself. And then, of course, the patient, once I got to know her and her diagnosis and her story, and even just who she was as a person, reminded me a lot of my aunt, which was very special.
I think that's a great place to end this also. What a wonderful thing to think about. It has been such a pleasure to have Dr. Jessica Moore to discuss her essay, Room 402. Jess, thank you so much for submitting your article and for joining us today.
Thank you so much for having me. Truly, it was a pleasure.
If you've enjoyed this episode, consider sharing it with a friend or colleague or leave us a review. Your feedback and support helps us continue to have these important conversations. If you're looking for more episodes and context, follow our show on Apple, Spotify, or wherever you listen, and explore more from ASCO at asco.org/podcasts. Until next time, this has been Mikkael Sekeres for JCO Cancer Stories, The Art of Oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.